A range of blood disorders, as well as there is a range of multiple vascular diseases that can manifest as the retinal pathologies in an individual. Now, whenever we classify these retinal vascular diseases, or either it can be the blood disorders, one should know that we have a group of disorders which can be congenital on one hand, and on the other hand, we have the acquired conditions of the blood. There are the blood conditions as well as the vascular conditions that can again affect the retina of the individual. So these are the multiple pathologies that we're going to discuss over here in this lecture, ranging from the congenital disorders, ranging from the disorders that are acquired, and what are the treatment guidelines that are associated with it. Now, whatever the cause may be, one should know that the main guideline for the management of such diseases would be to treat the underlying cause that is responsible for the basic pathology or the basic retinopathy in that particular individual. Over here, we will discuss these range of diseases that are particularly related to the retinopathy in a particular individual. So the sickle cell retinopathy, whenever we have or we are suspecting this kind of a sickle cell retinopathy in the individual, one should know that usually you would come up with a patient and he or she would give you a history of a decreased visual acuity. So when you start investigating such patient, you would find in the particular history even would give you these particular clues towards this sickle cell retinopathy in the individual. Obviously, you would look for the particular signs and symptoms in the fundus of the individual, but before going to that step of the clinical evaluation, you have to particularly take the history in detail in this particular individual of sickle cell retinopathy. The age again is very important. The female gender is more prone to the development of the sickle cell retinopathy. Again, it's a congenital condition. Sickle cell anemia is basically characterized by there is an abnormal oxygen carrying protein. So that is basically responsible for the peculiar shape that is basically a sickle shaped of the red blood cells in these individuals. Now, these cells are important for the carriage of the oxygen in these individuals. So they cannot function properly. The red blood cells are not functioning in a proper manner, obviously. This particular pathology is going to be sensed by the individual, or is going to be sensed by the retina of the individual as an ischemic condition, as an anemic condition. Again, it is going to lead to the different stages of this particular sickle cell retinopathy, ranging from the stage 1, in which there is a slight anastomosis, there is a slight dilation of the arterioles and the venules, and finally the neovascularization. The fibroelastic tissue is going to lead to the fibroelastic cartilage formation. The tractional force is going to be there, and finally there is going to be a stage of retinal detachment in these individuals, which is going to peculiarly affect the visual acuity, and obviously it can even lead to blindness in a lot of individuals. So these are the, in short, you can summarize the range of events as starting off from ischemia or anemia on one hand, and they're going to lead to the loss of the vision in the individual. The peculiar clinical features of this condition would be a venous occlusion. Obviously, these sickle cells are quite clumping in nature. They can form clumps in the veins, they can form clumps in the arteries, and finally, these clumps can lead to the areas of the ischemia. The blood is going to be hindered to these particular areas in the retina. And obviously, after this ischemic areas are formed, the neovascularization is going to take place. New vessels are going to be formed, and even the new AV shunts, that is the arteriovenous shunting systems, are going to be developed to overcome this ischemia or anemic condition. So as you can see, it's basically a compensatory procedure that is taking place in the individual. The body of the individual is going to sense this condition as an emergency, and these AV shunts are going to be formed over here. So this is the basic pathogenesis or the basic pathology over here. Now there is a range of the stage-wise conditions or the stage-wise clinical features that is going to appear on the retina of the individual. When you're going to observe the fundus through the ophthalmoscope or through the fundoscope, you're going to observe these particular changes in the individual. These changes can range from the peripheral arteriolar occlusions and ischemia, as you can see over here. The arteries are occluded due to the clumping phenomena of the sickled cells, and as well as after this clump formation, it's going to hinder the blood flow to particular areas of the retina, as well as these areas are going to be found ischemic. Although there's going to be a stage in which there is going to be the compensatory changes, that is the neovascularization and the AV shunt formation. But if it is the initial stages of this disease, the retinopathy is still to develop in these individuals, you are going to sense this particular changes in the fundus of the individual. Then obviously you're going to see the peripheral arteriovenous anastomoses. As you can see over here, there are the links being created between the arteries and as well as between the veins. So this arteriovenous anastomosis is basically a compensatory changes that are being formed over here in the retina of the individual. Then there is the vitreous haemorrhage. Why does this occur? Obviously, after the formation of the new vessels, after the formation of the AV shunts, these AV shunting phenomena or these neovascularization, there is going to be an abnormal leakage phenomena in the vitreous or in the posterior chamber of the eye, and that is going to be sensed as the vitreous hemorrhages. What are the clinical symptoms that are associated with this vitreous hemorrhage? Again, the patient is going to complain of the floaters in the visual field. These floaters are peculiarly related to the vitreous hemorrhage. So one should know it's almost the stage 3 of the sickle-cell retinopathy whenever the patient is complaining of floaters in the visual field, as well as the investigations reveal that the patient is suffering from the sickle cell anemia over here. So then we can have the vitreoretinal traction bands. So once you have the new vessels being formed, and once you have the AV shunts that are abnormal, the vascular walls are abnormal in nature, the fibrous tissue is going to lead to the tractional forces. These new vessels are going to lead to the tractional forces. And finally, these tractional forces are going to lead to the retinal detachment phenomena. That is, the retina is going to be detached, which is again an emergency. So as you can see over here, these are the different stages you can see in a sickle cell retinopathy over here. Leading to the knowing the different stages of this particular retinopathy, you should know what can be the treatment guidelines to it. It can be, obviously, on one hand, we can relate to the laser treatment of this particular retinopathy in these individuals, or either you can choose or you can opt for the surgical treatment, that is the pars plana vitrectomy being performed in cases of retinal detachment. So whenever you have a case of a complicated case of retinal detachment, you're going to opt for the pars plana vitrectomy in these cases. This is how you are going to remember it. These are the neovascularizations elsewhere. You can also have the neovascularizations at the disc or the neovascularizations at the macula. So the whole of the retina is at stake, and any of these structures can be involved. If it is the retina, the most central vision is going to be affected in these individuals, or either it can be any other visual field defect at your hand. So whatever the case may be, or how severe the case may be, one should know that the treatment guidelines would be to choose from a focal treatment of the laser, from the grid treatment of the laser, or from a surgical treatment on one hand. NVDs would be the neovascularizations at the disc in this case. Then we have the pre-retinal hemorrhages as well. You can see over here that sometimes these neovascularizations, they can, or the AV shunts, the AV anastomoses, they can lead to the formation of the vitreous hemorrhages or the pre-retinal hemorrhages in these individuals. Then we can have the dot and blot hemorrhages. They can be the most scattered hemorrhages seen on the fundoscopy or seen on the ophthalmoscopy in these individuals. Again, as you can see, we can have this almost 200 to 500 micrometers laser that is almost 4.05 to 0.2 seconds duration. So again, to remember its duration and to remember its intensity is very important when you're performing complete laser, or you're performing a focal laser, or you're performing a grid laser. Whatever the case may be, after counselings or after dealing with the whole management team, you're going to decide what kind of a laser you're going to carry out in a particular individual. Then obviously you're going to move on to the, if it is a case of the retinal detachment, if it is a case of a retinal traction, you're going to perform the pars plana vitrectomy. You are going to plan the surgery according to the condition of the patient and according to the complications that have occurred in this particular case of the sickle cell retinopathy. This is the retina of the individual who's suffering from the sickle cell anemia. We're going to have the light source, and on the other hand, we're going to have the vitrector. So this is a complete pars plana vitrectomy being shown over here. And if it is a bleeding that is taking place at any other new vessel, new vessels elsewhere, or new vessels at the disc or at the macula, if they're bleeding, if they're the cause of the vitreous hemorrhages, you're going to treat them with a vitrector at your hand. So once we have gone through the sickle cell retinopathy, on the other hand, we have a range of other anemic conditions. It can either be the sickle cell anemia, or it can be any other anemias. It doesn't depend upon the type of anemia that the patient is suffering from. Either it can be the thrombocytopenias or the aplastic anemias, iron deficiency anemias. Whatever the classification of the anemia may be, it can manifest as the particular retinopathies in these individuals. The only thing that is going to matter in these individuals who have retinopathies related to the anemic conditions is the severity of the anemia in these individuals. If the anemia is less than 50%, it is going to manifest as the particular changes. And if it's less than 35%, then the patient is going to suffer from the particular consistent changes that we're going to talk, or that we are going to summarize over here. And these are the particular consistent changes that the patient is going to suffer from. The duration of anemia is not going to affect. So the particular features that are going to affect the retinopathy is the severity, or the how complicated the anemia is in these particular cases. The clinical features, you should know by hand what are the clinical particular picture that is presented in cases of anemia. What are the causative factors, or what are the risk factors for the development of these retinopathies in these individuals? So first of all, anoxia, knowing the pathogenesis, the anoxia is going to be sensed by this individual, by the retina of this individual, that there is a decreased oxygen flow. Anoxia is the decreased oxygen that is being flowed to a particular tissue of the retina. So this is going to be sensed, and there is going to be an increased capillary permeability in these individuals. And then finally, when there is a vasodilatation that is done, and there is an increased capillary permeability, there is going to be the venous stasis in the vessels. And finally, there is going to be an angiospasm that is seen in these individuals, and foremostly the permeability of the vessels is also going to be affected in these individuals. So these are the particular range of pathological features that is going to end up in the particular retinopathic conditions in this individual. So finally, the thrombocytopenia is going to encompass in these individuals as well. Now, the anemic features that are going to be seen in the individual who is suffering from anemia and they have retinopathy coupled up with this particular systemic condition of anemia is going to be coupled up along with it. So, what are the fundoscopic changes or what are the ophthalmoscopic changes that you're going to observe in this particular patient who is suffering from anemia? You have a fundus that is quite pale. The background is going to be appearing, this pallor is going to be seen in the background. That is quite characteristic of the anemic condition or a patient who is suffering from anemia. Then finally, we can have the retinal arterioles that are quite pale in these individuals. As you can see over here, all of this is basically pointing out towards the systemic effect that anemia is being prevailed in the individual. And then finally, we have the retinal veins that are tortuous and dilated. Again, it's quite a compensatory change that is being followed over here. To cover up that anemia or the deficiency of the blood, the anoxia, to cover that up, the compensatory changes are going to be seen in this particular patient. The veins are going to be dilated and they're going to be quite tortuous in this particular case. Then finally, we can see that there are these particular retinal haemorrhages that are also going to be observed in these individuals. Again, these tortuosity and the dilation of the veins is going to hinder the normal vascular permeability. And finally, it is going to lead towards the retinal haemorrhages in these individuals. Rot spots are basically the hemorrhages with white centers. So it's basically a kind of hemorrhages that you usually observe in these anemic retinopathies. With the white centers are basically the fibrin that is collected inside the hemorrhages. So these are basically known as the Rot spots, and they're quite characteristic in patients who are suffering from anemia. Then finally, we have the cotton wool spots, and they are particularly notorious for the thrombocytopenic patients as well as the patients who are suffering from the aplastic anemia. These patients particularly would be giving you this particular picture of the cotton wool spots in them. So all of these changes are quite peculiar in a patient who is suffering from anemic retinopathy. Along with this particular clinical features, you're going to systemically examine the individual as well. When you are performing the systemic examination, you are basically making the diagnosis more clear in your mind. The anemia, the features of anemia are going to be seen, and they're going to be coupled along with that. Having the knowledge towards the clinical features would be a general pallor in the individual, as well as you can observe the other systemic changes that are taking place along with the anemia. It can be even the nails can be even examined in these individuals. So it's the nails, the eyes, all of these will give you a pallor, and all of this is going to contribute towards the diagnosis of the anemia in the individual. Then obviously all of these clinical features are going to be coupled up with the investigations that are carried out in the individual as well. The blood CP would be the foremost investigation, and that would basically help in the diagnosis of the anemic retinopathy in these individuals as well. The treatment would be, of course, directed towards the treatment of the anemia in these individuals. Obviously, the treatment would be the intravitreal tissue plasminogen activator in a lot of patients. Then you can also perform the YAG posterior hyalodotomy. So it can be subhyaloid hemorrhages that are seen in these individuals of the anemic retinopathy, and to cover up those subhyaloid hemorrhages in these individuals, you're going to perform the YAG posterior hyalodotomy in these patients. Then in a lot of patients, if you have the bleeding vessels, they can be treated with the pars plana vitrectomy if you are dealing with a patient of the retinal detachment. that is also going to be treated with the pars plana vitrectomy. So these are the different treatment modalities that are out there and that are basically related to the management of the anemic retinopathy in the individuals. But you have to keep in mind that regardless of all of these specific treatments that are present to deal with these patients of anemic retinopathy, you have the other general treatments as well. Treat the anemia, that is basically the underlying cause for the development of this retinopathy. So that would be the basic aim, to treat the underlying cause first of all, and then move on to the treatment of the specific changes that are taking place due to the anemia and they are leading to the retinopathy in the individual. That would be the basic highlight over here. Then moving on to the leukemic retinopathy. So even leukemia can manifest as retinopathy in a lot of individuals. So having these leukemic changes, the abnormal white blood cells can lead to the retinopathy in a lot of individuals as well, ranging from these dot blot hemorrhages that occur in these leukemic changes due to the abnormal white blood cells that can take place in these individuals. Usually you would have a pale fundus that is observed in these individuals. The veins are going to be tortuous and they're going to be dilated. The arteries are going to be basically pale and narrow in these individuals. As you can see over here, there is a narrowing of the arteries that is observed, and the veins are usually dilated and they are quite tortuous in these individuals as well. After this differentiation of the arteries and the veins, you can see that there is some sort of a leukemic infiltrate that is present as well. Then the patient can have the subhyaloid hemorrhages as well. The patient can suffer from rot spots appearance. As I've already mentioned, rot spots are basically the hemorrhages that have the white centers due to the fibrin collection in them. So these are the particular changes that are going to be seen in the fundus of a patient who is suffering from leukemic retinopathy over here. Dealing with these patients of leukemic retinopathy, one should know that the history taking is again very important over here. You should know how to take the history in detail with these patients of leukemic retinopathy. That would basically reveal the condition of leukemia. Finally, when you have taken the family history, the drug history, and the complete history of the presenting complaint, you're going to document that, and you're going to further on carry out the investigations in these individuals. That is going to further reveal that the patient is suffering from basically leukemia. Once this has been confirmed, these ophthalmoscopic changes or these fundoscopic changes would reveal the retinopathy that is coupled up with the leukemia in these patients of leukemic retinopathy at our hand. Then we have another, you can again say it's a vascular condition, or it is again a condition that is predisposing a person towards retinopathy. It's either a vascular condition or a blood disorder. It's not a congenital blood disorder, but it is basically a risk factor towards the premature infants that are making the premature infants more prone to the development of retinopathy. What are the different events that basically make the infant more prone to the development of retinopathy? Just to give you a background knowledge towards the development of the retina in an individual. At almost 8 months of gestation, the nasal periphery, the retinal vessels at the nasal periphery are completely formed. And almost 1 month post-delivery, the temporal vessels are completely formed. We are talking about the temporal vessels of the retina. They are completely formed. So this is the usual development of the retinal vessels when we talk about it in terms of the infancy, when we talk about the different congenital conditions that can lead to the abnormalities of the retinal vessels. So knowing or having this background knowledge towards the development of the retinal vessels make it more clear that any abnormality, if it is taking place, or any sequence of events that is contributing towards the pathology of the development of the retinal vessels would take place almost at the 8 months of gestation or 1 month post delivery, because that is the crucial time period for the development of the retinal vessels in the individual. The risk factors for the development of the retinopathy of prematurity would be the low gestational age, especially less than 32 weeks. So whatever the child's gestational age may be, if it is less than 32 weeks, that makes the child more prone to the development of the retinopathy of prematurity. Then again, even if the gestational age is normal, even if the gestational age is almost 32 weeks, a low birth weight, how do you define a low birth weight is again important. It is less than 1500 grams, especially less than 1250 grams. So having a low birth weight in between these ranges would again make the infant more prone to the development of retinopathy of prematurity in these individuals. Then finally, the supplemental oxygen therapy that can again make the patient more prone to the development of this retinopathy of prematurity in these individuals. Then finally, the light therapy. So these are the risk factors you have to keep in mind. It's not the prematurity that is affecting the retina of the infant. It's the treatments that are modulated for a premature infant, that is the risk factor. Whenever we make the patient towards the supplemental oxygen therapy, that is basically a hyperbaric oxygen. The infants who are premature or they are low birth weight babies, they are exposed to this supplemental oxygen therapy or they're exposed to this light therapy, and this is the risk factor. This is the basic factor for the development of the retinopathy in these infants. Then the vitamin E deficiency. Obviously, a low birth weight baby or an infant who has a low gestational age is basically suffering from the vitamin E deficiency, is more prone to the development of the retinopathy of prematurity. These two factors that we just discussed over here, that is the supplemental oxygen therapy as well as the light therapy. These are the usual features whenever you have a baby or you have an infant who is low birth weight or who has a low gestational age. They are more prone to the development of these diseases over here. So over here, you can see that there is a respiratory distress syndrome. And then finally, we have the asphyxia being seen over here as well. Now we have these different stages for the retinopathy of prematurity. Whenever the patient is exposed to the hyperbaric oxygen that we were talking about, that is going to lead to an increase in the VEGF and as well as the IGF. These are basically the growth factors for the arteries and the venules. And whenever these growth factors come into play, they are going to lead to the new vascularizations, to the development of the new vessels at the disc, as well as at the macula, or as well as it can take place anywhere in the retina. So these new vascularizations would lead to the different stages of the retinopathy of the prematurity that we're going to observe over here. In the stage 1, obviously, you're going to see the demarcation line. So this demarcation line is basically between a pale fundus on one hand, and on the other hand, you have the new vessels being formed. So this is the first stage for the development of the retinopathy of prematurity. Then we have the stage 2, that is basically in which we have a complete ridge being formed. This demarcation line, as we saw over here, it was quite pale in color. You cannot really appreciate this over here, but as you can see over here, this is a complete ridge being formed, and that is basically characteristic of the formation of a demarcation line between a pale fundus, and on the other hand, we have the neovascularizations being taken place. At stage 3, you can see that the formation of the neovascularizations or new vessels being formed are having those tractional forces. These tractional forces are going to be due to the development of the fibrous tissue of the new vessels at our hand. And then finally, these tractional forces are going to come into play, and they are going to have their changes on one hand. We have almost 2 separate stages for stage 4, that is stage 4A and stage 4B at our hand, depending upon the amount of the traction that is being carried over here. It is going to affect the final outcome of the retinal detachment, whether it is going to take place after this retinopathy of prematurity has taken place or not. So that will basically lead to the development of this particular stage 5. Stage 5 is basically characterized by the formation of a total retinal detachment. Total retinal detachment would be seen like somewhat, as you can see over here in this characteristic ophthalmoscopic finding, it would be a particular funnel-shaped appearance that would be observed in this stage 5 of the retinopathy of prematurity in these individuals. Then finally, moving on to the zones of the retinopathy of prematurity. As you can see, we have the zone 1 being over here, we have the zone 2 over here, and then finally we have the zone 3 at the peripheries over here. As you can see over here, this is the zone 1, and then we have the zone 2, and then finally we have the zone 3 over here. The zone 1 is somewhat ranging 2 radiuses towards the macula. When we see the zone 2, it's almost 2 radiuses located temporally or nasally, and then the area that is outside the zone 2, or that is towards the periphery, most temporarily, usually it is most temporarily located, that would be regarded as the zone 3. Why do we divide the retina into the zones whenever we are categorizing the zones of the retinopathy of prematurity? It would affect the visual acuity of the infant. Obviously, when we are calculating the visual acuity of an infant, we cannot have the Snellen chart at our hand. We have to relate to the visual acuity by these zones. We're just going to say whether the macula is involved or not, whether the central vision would be affected in the child or not. So these are the particular zones. It's just for the documentation purposes and just for the planning of the management of this retinopathy of prematurity in these individuals. So knowing these zones would make it easier for the individual just to document or just to foresee the kind of the visual field effect in this particular infant who is suffering from the retinopathy of prematurity. So just to sum up this particular condition, you should know that the risk factor was the exposure to the hyperbaric oxygen, which definitely led to the increase in the vascular endothelial growth factor and the intermittent growth factor, and that led to the formation of the new vascularizations in the different zones of the retina. If it's the central zone or if it's a zone 1, that is the most affected or that is the most severe state of the retinopathy of prematurity in these individuals. Then finally, we have the pathogenesis towards it. As you can see, the post-menstrual age is again very important. We have a premature birth. That is going to be the most important risk factor over here. The normal intrauterine oxygen and the VEGF is the normal appearance of the retinal vessels and the normal development of the retinal vessels over there. In phase 1, when you have an increased oxygen and a decreased vascular endothelial growth factor, the vessel growth is going to be stopped over here in the normal phases. But in retinopathy of prematurity, we have a phase 2 in which there is a decreased oxygen, there is an increased growth factor phenomena, and the new vascularization is going to be increased over here. Then finally, it is going to be followed on with a decrease in the VEGF, and new vascularization also decreases along with it. The normal intrauterine vessel growth Then we have a stage 0, the gestational age at high risk for the development of this particular stages. The stage 1 is the development of the particular demarcation line. The stage 2 is the development of the particular formation of the ridge. Stage 3 is the tractional phase. And the tractional events are, it can be either a partial retinal detachment in stage 4, or it can be a complete retinal detachment or a total retinal detachment in stage 5 of these individuals. The first examination for the retinopathy of prematurity would be almost at 35 weeks of gestational age. That is, the onset of the retinopathy of prematurity is marked at this age. This is the stage 1. That is almost 35 weeks of gestation, or less than 35 weeks of gestation is the development of it, and then it goes on to the stage 2, that is the formation of the demarcation line due to the development of the new vessels, or due to the development of the new vessels at the disc or new vessels elsewhere in the retina. Stage 3 is the formation of a particular ridge over here. After the stage 3, you opt for cryotherapy, or you opt to basically minimize the formation of the new vascularization in these individuals. The treatment is started off immediately after therapy, or even it can be delayed for almost after several weeks after birth, depending upon the management guidelines that you're following at your hand. Laser therapy is sometimes performed along with it, and sometimes a lot of drug therapies. For example, bevacizumab is one of a drug that is given for the new vascularizations over here in this retinopathy of prematurity. The other features would include the pulse disease. Then we have a pre-pulse disease in which there is no retinal detachment seen. And then we have a threshold disease in which there is neovascularization, but there are no hemorrhages, or there are no tractional forces. No ridge formation is being seen in these cases. We have, on other hand, the aggressive posterior retinopathy of prematurity seen at our hand. And then finally, we have the pre-threshold disease. So these are basically the range of diseases depending upon the severity of the disease in the individual. The differential diagnosis would be an active retinopathy of prematurity in the individual. And then finally, we can have the familial exudative vitreoretinopathy. We have to differentiate this particular condition with incontinentia pigmenti. We were going to again differentiate it from the persistent fetal vasculature. So it can be the abnormality of the fetal vasculature independent of the hyperbaric oxygen that was given to the individual. The advanced vitreoretinal fibroplasia, that is again one of the varieties of the this particular condition in which there is also the neovascularizations seen. So all of these conditions have a similar factor that you can see the neovascularizations, or either you can see the retinal detachments being seen in these conditions. So you have to know how to differentiate this condition from the peculiar other conditions over here. Now, knowing the primary retinal telangiectasias are also known as the spider webs. So these are again familial in their nature. They are congenital in their nature. It is a particular blood vessel disorder that is characterized by the thin blood vessels that are clustered along the skin, or either they can be located at the retina as well. So these clusters, or these thinning of the vessels, is seen as seen over here in this particular ophthalmoscopic finding. It can either be the idiopathic juxtafoveolar retinal telangiectasia. So these are the particular varieties of the telangiectasias that we can observe. They are again congenital in their nature, all of them. So idiopathic basically means that there is no particular pathogenetic factor or no risk factor for the development of these telangiectasias. The location would be juxtafoveolar. It would be almost near the fovea or near the macula. So that would be basically regarded as the particular condition known as idiopathic juxtafoveolar retinal telangiectasias in these individuals. Then finally, we have the Coats disease. Coats disease is again a retinal vascular disease affecting the most central vision in the individuals. It's a congenital disorder. And again, it is going to be seen like this. The milky white appearance is sometimes confused with the congenital cataract. So one should know how to differentiate with the posterior polar cataract with this particular condition of the Coats disease. The familial or the genetic factors are again very important, and they play basically a pivotal role in the development of this Coats disease in the individual. That is going to finally result in the retinal detachments in these individuals. As you can see, it is sometimes quite relatable to a congenital cataract that is present in the individuals, and the picture is quite confusing. So it's quite similar to a posterior polar cataract in these individuals. The ophthalmoscopic findings would be the pale fundus, and there would be hemorrhages found in the retina. And that is basically the pale fundus, and all of these features, the pallors are going to be noted down at the retina, and they're quite characteristic for this particular kind of Coats disease that we're talking about. This would be some of the special features for the development of the Coats disease. The retina is sometimes detached, that can be seen in the radiographic findings as well. When you ever perform these investigations for this kind of a Coats disease or for this kind of the telangiectatic conditions in the individual. The treatment would be to perform the laser, that is the photocoagulation therapies in these individuals, or either you can also perform the cryotherapies, that is the electric burning therapies, to burn down the abnormal vessels at the retinal walls, and the exudates are sometimes also going to be seen over there. Another form is the Leber's-Millery aneurysms. It's again one of the kinds of the telangiectasias that are seen at the retina. The particular picture would be this particular kind of a picture as seen over here. Usually it's a bilateral condition affecting the vessels of both of the eyes. You perform the fundoscopies, and sometimes you also perform the FFAs, that is the fluorescein fundus angiographies, just to see the patency of the arterioles and the vessels, and that would basically indicate the extreme thinning of the arterioles as well as the venules, and all of the vasculature would be affected for the retinal walls over here. Then finally, knowing the ocular ischemic syndrome, it's again very important that a lot of systemic diseases are going to manifest as the ocular conditions in the individuals. One of the notorious diseases is the diabetes mellitus and hypertension, increased cholesterol levels. All of these are going to affect the ocular condition, or they are going to they're going to have their specific effects on the retina as well as the lens, the capsular changes. They're going to be taking place over here. So these are the particular dot blot hemorrhages that can be seen at the retina. And all of these conditions in which even the anterior chamber is sometimes involved in these particular changes of the ocular ischemic syndromes. The etiology would particularly consist of the pathogenetic events that take place over here are the stenosis of the carotid artery over here. That is going to relate to the chronic ocular hyperperfusion. And this hypoperfusion is going to basically be sensed by the retina as an ocular ischemic syndrome that is going to lead towards these dot blot hemorrhages that are quite characteristic of this ocular ischemic syndrome over here. Then again, the manifestations of the carotid occlusive diseases, they are the amaurosis fugax, in which there is a sudden loss of vision. It's again painless, but it's a sudden loss of vision seen over here. We have a retinal artery occlusion. It can be a central retinal artery occlusion or either a branch retinal artery occlusion seen over here in these cases. Then any CVA, that is a cerebrovascular accident or stroke, can again manifest as the loss of the vision suddenly in a patient. Then we can have the TIAs, that is the transient ischemic cerebral attacks. So all of these systemic illnesses can manifest as ocular illnesses. And these are known as the etiologies for the development of the ocular ischemic syndromes. Then finally, we have the loss of vision, we have the transient blackouts if it is the case in the TIAs. Then it can be the pain, ocular or the periorbital conditions, the delayed dark adaptation in these individuals can be seen over here as well. The signs would include the cornea can also be affected. That is, the edema and the stria are sometimes noted down. The anterior chamber is affected in a lot of individuals, resulting in the ischemic pseudo-iritis. The pupils are going to be dilated and poorly reacting. And then finally, the iris is going to have the rubeosis iritis in these individuals. Cataracts are going to be seen as a complication of this condition of the ischemic syndrome. And then finally, the neovascular glaucoma is going to be seen due to the sequelae, due to the anterior chamber segment neovascularization. So all of these are going to be the signs that are going to be noted down as an ocular physician, as an ophthalmologist, or as a general physician when you're noting down the ischemic syndrome in an individual manifesting as the ocular conditions. The differential diagnosis would be the non-ischemic central retinal vein occlusion, the diabetic retinopathy in the individuals, then finally the hypertensive retinopathy, the aortic arch disease. So all of these systemic illnesses can even manifest as the ocular diseases in a patient. The investigations would include the magnetic resonance angiography, and then finally we can have the Doppler ultrasounds that are carried out for these ocular syndromes in these patients. The treatments would include the treatment of neovascular glaucomas, proliferative retinopathies. For proliferative retinopathies, you're going to carry out the pars plana vitrectomies or the photocoagulations, the pseudoiritis. Topical steroids are given. And then for the carotid stenosis, you're going to carry out the antiplatelet therapy, oral anticoagulants, and then finally the carotid and arterectomy. So these are the particular specific treatments as well for the particular complications, and then obviously the underlying cause is going to be treated along with these treatment guidelines. So in this particular lecture, we summarize the blood disorders, as well as the vascular disorders that can manifest as the ocular complications in an individual, or particularly the retinopathies that are related to these systemic changes over here. So that is the end of this lecture. Thank you for watching sqadia.com.